Welcome to Sutures and Cents. Wouldn't you like to know how an ASC, an ambulatory surgery center, looks at your new product requested by your surgeon or pain management physician or whomever, the due diligence they have to go through and how they look at it? Well, you're going to get a dose of that today because we're talking business to clinical, clinical to business, and business to business with Andrey Ibragimov. I'm Mark Copeland. I'm the Value Analysis Whisperer. Ryan Pistone is our prefrontal cortex of Sutures and Cents. He's the decision-making thought. Unless it's bad, then I probably made the mistake. But Ryan Pistone. You should follow him on LinkedIn. He talks about med device marketing. Really smart guy. But today, the really smart guy I talked to is Andrey Ibragimov. Now, here's Andrey's background. Andrey is an administrator at a system-affiliated ambulatory surgery center in the Chicago area. He's been doing this for a while. He's a nurse by training because he's also the president of the AORN chapter 1401 in the Chicago area in Illinois. And I assume everybody knows where Illinois is, and Chicago for that matter. He's also a board member of the Illinois Ambulatory Surgery Center Association. So he represents the interests of ambulatory surgery centers, small, large, system-affiliated, independent, GI, sports, general, eyes, all of it, regionally, locally, statewide. And he's a speaker at Becker's ASC, which I recommend. If you want to understand ambulatory surgery centers, spend a couple of bucks, go to Becker's, and just listen to the talks. Andrey is usually one of the featured speakers at it because he's so insightful. And I've gotten to know him. I consider him not only a friend, but tremendously educational. And I suspect I'm going to learn a lot today just interviewing him. Who knows what it's going to be? So I'm going to bring to you next Andrey Ibragimov of a Chicago, Illinois ambulatory surgery center and an administrator there, and how he looks at new products. So I've heard some crazy stories about reps bringing in new products that it's a physician preference item, right? For a case next week, and they show up the day before with instruments and people are like, who are you? Why are you here? And we hear about those stories all the time. I doubt that happens as much as it used to, but you work at actually a system affiliated ambulatory surgery center. So it's probably even more, you have probably a pretty good process for this, but what have you seen out there that you just shake your head sometimes with your vendor reps?
Yeah, thanks, Mark, and thanks for having me.
Hmm.
I think that so the system affiliated ASCs, I think, seen as less and less. The majority of our business, about 80%, comes from the system side, where the
Mm-hmm.
surgeons are really more trained and understanding that a lot of these things cannot happen and will not happen. I
Will
think
not.
that
Yeah.
will not happen. We've seen and we had this conversation with surgeons where, we get these calls and we immediately call the surgeon and say, you're not following the process, this will not happen. And, we can start talking to this person or this company or this vendor, but counting that this will be there tomorrow is not going to happen. There is 20% of our business comes from independent surgeons.
Mm.
And we've been system affiliated for, I think, close to 10 years now. And I think that a lot of these surgeons now understand and actually appreciate the fact that
Yeah.
we sort of shield them in a lot of situations, we shield them from
Yeah.
some of these things that are happening. And so when I get calls but from vendors that are dropping sort of independence names, I text them, and a lot of times I say, yeah, I really want you to protect me, and I know exactly what they're requesting. So,
Yeah. Okay.
yeah, so
Yeah.
I haven't really experienced that, I would say, in good 5 years.
Yeah.
where people just come in and start doing this. And when I started, I kind of untangled a lot of these situations where that were brought up. Nobody checked anything, and then when we actually look at the numbers, we were upside down in a lot of these situations, and
Yeah.
we immediately stopped this and talked to the surgeons and said, this cannot happen."
Yeah. So you did find where, when you say upside down, you basically mean you're losing money after all the bills are paid on that procedure,
Yeah,
um, based on the reimbursement either from, Medicare or the private insurer or whomever. Yeah, I hear these stories, and I'm not surprised. And so it sounds like, but I think those days are numbered. But I still think the number is higher than we would think. Although it sounds like you guys have a pretty good process in place, right? So I'm your rep. I've got a surgeon who operates at your place. And what is the process that you put it through now that you maybe like you had to, like you said, you had to untangle some things 5 years ago, and you
right.
guys have been doing this for quite some time, so you get less of it. So you're doing things in an organized process. How would you describe that to the audience that's listening that are vendor reps?
Yeah,
Basically,
absolutely. No, that's a great question, Mark. So system affiliated ASCs, and we obviously seeing this more and more, right? So like big systems are looking around at either partner with somebody or they develop their own. There's different ways of doing this.
hmm
So if you're, I don't know, if we are, if somebody reaches out to me and say, "Hey, this is a procedure, Doctor So and So wants to do this." First, we're the first question is, are you a onboarded, cleared vendor, right? If you are, this is it's going to make things a lot easier, but we still have a lot of work to do. If you're
Right. So
not,
it's not automatic. It's like sort of the first knockout question almost, right? If you're
exactly, yeah,
not,
it's
yeah, onboarded
yeah.
here.
So there's like this, we would
Mm,
diverge, right? Like, hey, there's a path of
yeah.
truly de novo vendor, right? Or if there is a path of, hey, this is a rep that is cleared. However, we have not worked before, right? So
Right.
those are two things. And the reason it's important is
Mm,
because a lot of systems use a vendor management um,
yeah.
softwares, and that sort of encompasses the entire thing from clearance to the billing to the actually reimbursing you and paying you the bill, right? So
Okay.
some of them are there's a few out there. I think that
Yeah.
you have
Are they
Trivalence, you have
like rep
Oracles.
tracks and yeah,
No, I'm talking
GHX
about like,
and
yeah, those exactly, yeah. So those are the
okay.
things.
Yeah,
So
yeah.
if
Mhm.
you're a system affiliated rep, you are going to be in a drop down window for me. So I actually find you and I can actually issue a PO. If you're not in the drop down window, I cannot. There's no way that I can issue you a PO and you're not
Mm,
gonna get paid. So that's where the first thing starts, right? And we partner with supply chain and to do. They have a whole sourcing team that works specifically on these issues. So if you're telling me I'm not a system affiliated, then great. My first call would be to the sourcing team and say, "Hey, Tommy, can you please let me introduce you to Stephen here, and
mhm.
please, Dr. So and so would like to use Stephen's product here. Can you please work with him to onboard this rep, onboard this vendor to our system?" And this
Yeah.
is where it starts, where you need to produce your, tax documentation. We need a contract signed
Right.
based on, so the contract might take a little while, and we business associate agreement. We don't take yours as a business agreement. We have a standard
Use
of
yours.
form
Yeah.
where we will provide it to you. You send it to your lawyers, redline it. Usually there's not a lot of redlining going on, but
No.
sometimes it
No.
happens. And then And then, once we sign it, then there is a system onboarding. It takes a few days. So I would say from the first call to sourcing to a vendor being onboarded, I would say plan for at least 2 weeks. That's if
Which
you're
well,
motivated.
and that's if I'm the vendor and I have everything lined up,
Ready.
chambered, ready to go. I'm just
Yeah.
not in your system
Yeah.
yet. And well, I will tell you though, 2 weeks tells me you have a pretty well-oiled system that if I
Yeah.
it's going to sound like the strangest thing I say today. If I'm well-oiled and ready to chambered and ready to go, you guys can do it as fast as I could. That's just about as fast as I could keep up, frankly. You know,
As fast as
which
you
is
can produce your documents. Exactly.
yeah, yeah. And this is here's my next less dumb question, but I'm telling you, Andre, like when people explain these things, um, I'm it always impresses me how many people go, "Oh, now I get it." Because a lot of vendors will say, "Well, why do we like honestly, why do we need to go through all of that?" Now,
Right.
I know why. But in a sentence or nutshell, why do you need to do that from your facilities perspective to make sure the vendors
Yeah.
go through this process
No, absolutely. I
other
think
than just
that,
getting a PO?
as we onboard you, right, we do the check about, where's your, FDA clearances,
Mhm.
are you, who is your local rep, who is your accounting representative. We explain how do you gonna get paid, where you need to submit your invoice after the PO was issued, that you're going to be onboarded to wrap tracks or whatever the OR tracks, whatever those things are.
Mhm. Yeah, all the different
And
ones. Yeah.
yeah, and then we will record you in our system that we're doing business with you, so for the tax purposes. Some
Yeah.
parts of our organizations are non-for-profit, others are for-profit. There is a lot of implications going around this. Like we telling you, if you submit the bill here, you need to include tax. If you submit the bill there, you don't include tax. So there is a lot of like as those organizations grow and become more complex, we also want our vendors to understand this and to be ready to deal with us. And that's how we do business.
Yeah, that's interesting. Uh, What you just described, I know I nod, but I'm like, yeah, but I never thought about it down to that specific detail where I know you need my EIN. I know you need to load me in as a vendor because you need to be, but I never really thought about it as to the tax implications that
Correct.
are important and required. But like that's that's you being well oiled in our
I,
system
I think
as
that
well.
this
It's
is
really
in the
interesting.
if I go back and think about like all these conversations with the reps, I think that I actually spend the most time about talking about taxes. And
Really?
a lot of them are very confused and frustrated by this because they say, well, we're dealing with with a medical center, they don't do this. And we say, that's great. And now you're dealing with me and we're for profit. So it means that you need to include tax. A
Yeah.
lot of times we also have options to, to deal with this on our end, but it's more work for us. So
Right.
yeah,
Yeah.
exactly. So we're, that's actually, that conversation comes up all the time. Like, but why? Because over there is non for profit. Like, yes, that's over there. And now we are over here.
Yeah.
So going back to what happened. So let's say
Yeah.
you are in the system, and now I say, okay, that's a very good first step. Now, a lot of times, the next conversation is going to be about the cost, and the
Mhm.
cost is going to be different. Some of the bigger companies started introducing tiered pricing, which means that if you're doing a case at the hospital, they understand that the reimbursement is higher and it's going to be one price. And then if you bring it to ASC, the reimbursement is lower, so you need to lower your price. I'm pretty firm on this, and there's different ways of dealing with this. I'm not going to go into what reps do, but my perspective is this: you need So then the vendor goes back and refers to the main contract and says, well, the main contract says la la la, and these are the prices. And I say, that's fantastic. The way we do things is that you need to produce a local pricing agreement, which means it's going to be a tag on to the main contract, which says that if your
Right.
case is done at this facility, the price is going to be different and it's going to be lower.
Yeah.
For that reason, I recommend always to bring your best price because I had multiple conversations in the past, 2 years with folks that are frustrated about this. And essentially, what we do, we leverage the situation in some cases to our advantage, and we say, okay, well, if you can do this at the AAC for lower price, then we're going to ask you to do the same at the hospital.
At the hospital.
Bring it, yeah. So, but again, some of these, the bigger vendors, they have tiered pricing and they understand the model.
If so, that's fascinating, and I want to hear more about your process, but I wanted to ask you a question based on that. Um, if every vendor on the planet walked in to you with an and said, "We do this now, tiered pricing," would that make your life easier? Like, would that make it easier for you to look them over? Because I've Andre, I'm amazed at. I started posting some of this stuff when you talk about the reimbursement to ambulatory surgery centers versus hospital outpatient surgery centers, and they're different. And like a lot of people didn't know. I didn't know that till 3 years
Right.
ago, and somebody explained it to me, and I'm like, oh, this answers so many questions as to why I had this conversation a couple years ago, So it's it's such an odd way things are done in the US on this. But
Yeah. I
would
think
you
that,
understand where I'm coming from on that question?
yeah, to answer your question, I think there's several facets to that. So number one is what is best for the patient, right? So if you're a vendor that is trying to provide the best care to the patient, you understand that, and that's the way to do things. That's one. Two, you are supporting the ecosystem, right? So you're we're seeing hospitals struggling. We're
Mm,
seeing some of the ASC struggling, and we're seeing the shift over there. So if you're doing the tier pricing, you support the ecosystem in general, and you understand what are the rules, so you don't cut the last tree like in Lorex, and then you find out like, okay, what's next, right? So we made all the money there is to make. What's
yeah.
next? So there's no more trees left. So I think that that's how I see that, so so we all sort of understand how to take care of the system so we don't end up in a desert.
Right. Right. Okay. Man, that's it's fascinating. Thank you. Thanks for talking about that. I'm telling you, it demystifies so much of this for so many people, including me.
Right.
So you were describing your process. Then we'll go back. So you're looking at the vendor clearance. Are they a vendor in our system? Then you said the next sort of part of the algorithm, I'll call it, is pricing and contract. And, you know, how do you then proceed from there as we're walking
Sure.
through these check boxes?
Yeah, so well, I think that if once we start walking and I say, okay, your vendor here, we're gonna need to do a local pricing. At this point, I usually schedule an interview with the vendor where,
Mm,
you can do it in person, you can do it over the phone, you can do it over Zoom, but we that's the necessary middle step between you are in our system, and then we need a local agreement. I usually it's very structured in the way that I need to understand what exactly are we talking about, right? What is the thing? So I usually tell them it's going to take about 20 to 30 minutes, depending on the complexity here. And so I schedule a call and we just start going through my questionnaire. And first thing I understand is like, what is the name of the procedure we're trying to do?
mm,
They give me the procedure, and we're going to say, okay, do you have an FDA approval for that? Is this FDA cleared? They usually say yes. Okay, do you have a published literature about this, the
Mm,
benefits of your product? If it's FDA, you need to produce some research, things like that. If the answer is yes, I'd like to see it. I'd like to at least understand what are the benefits, what are the sort of the risks here, what's the number of people that this research was done on, right? We started talking
mm,
about, N of 10 versus N of 10,000 is different. Obviously it's not going to be 10,000, but,
yeah.
we're looking for somebody more than one. Um, we're looking at we're looking at the CPT code. Is there a CPT code approved in that? And a lot of times, this is amazing. People say, "Oh no, there is no CPT code. It's new procedure, but you need to use an unlisted code." That's where usually things stop
Hmm,
because um, and the follow-up comment would be, well, we've done this at the hospital and they use the unlisted code and they use the code. Did they actually got paid on that code? That's a different
right,
story.
right,
Most of the
right.
time, they're not going to get paid on that unlisted code. Or there's going to be a denial and then it's going to be more follow-up process and things like that. So 12 months later, you might get something. But the fact that you use the unlisted code does not mean that you're going to get paid. That's one. Two,
Wow.
most of the ASCs and the ASCs, those codes, unlisted codes, are not even listed for the ASCs. So that's where I go and say, is this on the CMS procedure list, right? So the CMS has an inpatient only list of the CPT code, and then the CMS has the ASC list that gets updated every year. And there's a lot of
Yeah.
discussions every year at all these
Right.
conferences about what was added, what was removed, and things like that. So those unlisted codes are not there for ASCs.
Wow. So, just out of curiosity, because I never thought about this. As usual, every time I talk to somebody who does this, like you, I learn things. I'm like, okay, never thought of that either. Right? Unlisted code. If you were to do a procedure that was an unlisted code or not on the CMS, it was only on the CMS inpatient only list. Let's say it's not CMS. I guess approved would be the term for ASCs. It- Not only do you not get paid, I would think you're in some jeopardy, right? Like,
Yeah. Absolutely. Or
yeah,
they're bringing in an implant and says, well, there's a CPT code on this implant, but the CPT code on the implant is tagged on to a different code. So on the ASC side, there are a list of
mm,
codes that are a it's called I don't the word escapes me, but it's something like combined, a bundled code, I think. It's called
oh
bundled
yeah,
code,
bundled codes. Right, right, right.
which means that you can bill this, but you won't get additional payment. I think for CP for Medicare, it's like they called N1 codes, where they're listed, but there's no payment to them.
Right, right.
So you're
Man,
you're coming in and you're saying, "Hey, this is great. We have this, we have this code," and you're like, "Okay." You look at your fee schedule, and there is no payment. And then you go into the classification. It says N1, which means you cannot get paid on this. So you can try to bill it as an implant, but
you could
it's
do anything you want, but it
yeah,
doesn't mean you're gonna
yeah,
get.
exactly.
This is as usual. I'm telling you, Andre, I end up in areas talking to people like you. I did not anticipate. I didn't know, and it's one more thing. Like this is you're describing this due diligence you have to go through, which is
Yeah,
uh, because of all these risks of non-payment, risks of some sort of jeopardy of doing it. And it's interesting. Like I was thinking about this as you were describing it. I think shoulders were now CMS approved to move into. I think shoulder arthroplasties now,
ASC.
right?
Yeah,
And ASCs, and that's a relatively new phenomenon, or it's
I think
about to. I
it's
can't remember. If it's,
I think
I
it's
don't.
it was added last year, yeah.
Yeah.
For this
Eh,
year, you mean?
So
Yeah.
that's an example of a procedure that a surgeon could possibly want to do a great. They could do it very well in an ASC. An ASC could do it really well, but it wasn't approved, so they weren't going to get paid, and they're in some jeopardy.
Exactly.
It's really right.
Yeah.
That's sort of, and you have to triple check those things. I mean,
Yeah.
that's it. It's
So
interesting. You brought up stuff I never thought of.
yeah. So we're going to the CPT code. Let's imagine you have a CPT code and we
Hmm.
say, okay. So then there we have some sort of the part two of the interview, we're going into more clinical stuff. So what is the length of the procedure? And people usually say, well, person down in Texas can do it in 45 minutes. It's fantastic. Um, this is a new procedure for the surgeon, and a lot of times the companies require training. So for the surgeon, did the surgeon completed the training? No, but he's scheduled. Okay, that's great. So we're certainly not going to do it next week or until the surgeon completes the training. So those are the things. A lot of the times, those training is tiered. You have to do a online training, and then you have to do a lab where you actually try that. So once you complete this, please send me the certificate so I actually can do this. A lot of times, these procedures are not on your approved list. Every ASC has to maintain a procedure that's been approved by the board. You do this every year. And moreover, this procedure might not be on the credentialed list on that is the surgeon is credentialed for it's called delineation of privileges. Essentially, every procedure that this surgeon is able to perform at this ASC is delineated in his privilege list. And if that procedure is not there, they have to request it. They have to prove that they're trained. So that's where the certificate comes from. They have
Wow.
to, if they've done it on the hospital side and now they want to bring it to ASC, they have to give me a log of these cases at the ASC. Our medical director will review it. And then and formally request addition of that CPT code, that procedure to their privileges. So this is what
Yeah.
and this happens all the time. People coming in say, "Oh, that's fantastic, new pain procedure. We just developed this, great reviews." But this is a whole new procedure, not on the privilege list, not on the ASC procedure list. So we have to go through all these steps just to add it.
Yeah. And okay, I, you just talked about two more things I never thought about, right? Which is this is why I interview people like you because, frankly, I'm selfish. I learn, I get better at this. But so those are not, I know that's not every time, but you're saying this happens a lot, right?
This
So
happens a lot,
these are
especially with the
things
new
that,
stuff,
yeah,
new
yeah,
technology.
right, right, yeah. That's. You gave me more things to think about today. Going, well, didn't know that either. Like
Yeah,
it's very humbling sometimes interviewing people like you. Uh, so you're working your way through this process. Oh,
working
by the
with
way, you have an ambulatory surgery center to run. You got staff things. You got like
yeah,
this
yeah.
isn't what you do all day long.
So then we go and say, I always ask, what's a known complication? And that's because, most AACs that I know don't keep, things like blood or blood products there. There's no way to do this. And, I'm trying to gauge my risk. What is the risk of patient being transferred out or need some sort of treatment, resuscitation
Right.
treatment because of the
Right.
complications. So I always gauge my procedures and gauge my risk and risk for the center, if we're doing this.
Yeah.
And then we're going to go into the volume. What is the volume of this kind of stuff, right? So if somebody says, hey, usually we go into the situations where like, oh, like once or twice a month, which translates in maybe once a year, because once or twice a month, it's this
Yeah.
coded sort of a thing, like not a lot. Um,
Right.
and then at this point, I'm trying to understand, is this even worth, if the juice is worth a squeeze? If
Right.
the surgeon comes up to me and says, hey, I absolutely believe that this is the best treatment for my patient, patients comes first. We will do the necessary work. but we also, need to understand if it's like one of the 5 ways of doing that procedure, and we're gonna jump through all these hoops, the privileges, the ASC list, the vendor, and all of that. Are we really is it really needed?
Yeah.
And
Yeah.
we've done it many, many times where you bring it in this doing this one procedure, and that you would never do it again. And unfortunately, I do have examples, and I've done this in the last couple of years where we bring it in, we jump through all of this, we buy 5 boxes, we use it one time, and we never do it again. And I go back to the surgeons every time I see them, so there's 4 more boxes sitting over there. When are you going to use them? And they usually look down and walk away. So, yeah,
Yeah. Sorry. I know how frustrating that is to
yeah,
occur. And thank you for talking about it here in Copeland's therapy session. We're having therapy here today. But yeah, I've seen
so
that, and it's frustrating. I can only imagine how frustrating that is. I've not done your job, but I've seen that. And, um, and it goes right to your bottom line, and it goes right to the credibility of all this. And you went through all this work because you do try to do what's best for the patient, and then you got stuff sitting on. And by the way, you don't have a ton of shelf space to begin with, and now you got
that's
stuff
yeah,
sitting there that you
exactly.
bought.
Yeah.
Right?
So
It's
usually it
crazy.
goes down and down and down, and then it sort of disappears from the main supply room, goes to this like a junk supply room, and then
Yeah,
from there it goes to some storage. Yeah, absolutely.
yeah,
So going back to the interview, so then we kind
yeah,
of go into the part two, which is more clinical, right? So we're just talking about well, not really more clinical, more of a business actually, because we just
mm, mm,
reviewed all the clinical stuff. So
hmm
like, hey, is the capital required? If the capital is required, that is a whole different ball game. You're talking about it's obviously not in this capital year. I've just first time I've heard about
yeah,
it, and we can put it on, but this is definitely not a pressing priorities. I'm sure administrators that are watching this right now, thinking about all the capital things that were denied in the last 5 years that are really needed. We're
yeah,
not talking about the new procedure. If the capital is not required,
right.
then we're talking about disposables, right? So what is the disposables? Or if there is also sometimes it's placement, right? Hey, don't worry about the capital, we'll place it. And then they say, if you put a $25,000 order.
They actually sort of subtly, they don't quite
Yeah, they
whisper
just
it. They
like,
just
yeah,
sort of
just
like
kind of like whispered it. I mentioned it. You didn't hear it, but I did
cough.
mention it. It happens all the time with these placement things. Like, yeah, we'll give it to you for free if you place a $25,000 order for the procedure of one, and the rest will just sit on the shelf. So,
That doesn't sound
yeah,
like it's free.
yeah. No. So if we're gonna go, so we'll say, okay, disposables.
Yeah.
If it's is it a bill only process? If it's a bill
Mm,
only process and you're a approved vendor and there is a CPT code and this is a good solution, we prefer it to do it this way. Then if you're saying yes, this bill only process, okay, what is in the kit? Usually some
right.
companies a lot of companies are going into this kits, right? Procedure kit, everything's inside there. What's inside the kit? Because there is an implant, which is one item out of 10, and the rest of
Yep.
it is some kind of a specialized K wire. There's a specialized blade, there's a specialized trocar, there's specialized depth gauge, and things like that. Things that you cannot bill for. The only thing that you will actually bill is this one
Is the
implant,
implant.
right? So they say, "Oh yeah, it's everything's included," but I do have the blade sitting on my shelf. I do have these trocars or K wires and all of that out there, so I don't really need them. But they, a lot of companies do the kits, so
Hmm.
which is fine. But
Hmm.
again, I have to understand which part is the actual, the because they say, "Oh, the reimbursement is so much." Let's say for the simplicity, $5,000. You'll get paid for this. And we say, okay, well, that sounds pretty good. So how much is the kit? this is where like, oh, I don't know, I need to check the pricing, things like that. But usually it's going to be 4,200 to a 4,500, and they're saying like, but you also get the procedure fee. Yes, we do get the procedure fee, but we also have other ways of doing this stuff. So your
Right.
kit is one of three ways of doing this. So it's not exactly a pressing issue. So we need to come down on this price because we are dedicating a lot of capital, I mean, a lot of our cash
Y-
flow to your
Yeah.
kit. And we haven't done it, so we may or may not get paid. So, so that's the sort of a thing. Then we sort of go into reimbursement where there's a dance about the side. I don't know. Let me call the district manager and all of that stuff. For us, it's a lot easier because we have a pretty good process about here's your GPO, here's the bundle pricing, we're doing the check, we're doing the Medline, what's it called? Um, Basically, we're checking the price, what other people
Oh,
paid for
right.
it, and
Right.
things like that.
Yeah.
Yep.
Hmm.
And then I finish with usually like the support of like what's the support of approval if it's a new procedure. Usually these vendors have some sort of a reimbursement support. Is it support for get this approved? Or is there support for denials and things like that? And those also can be very tricky because you're exchanging medical information, and
Right.
in the days of all these cybersecurity things, those are pretty tricky transactions,
Yeah.
and
Do
it's
you, do
require
you
a whole
find those?
separate.
Oh, I'm sorry. Do you find those generally, despite the trickiness you just sort of described, do you find those reimbursement sort of hotlines or support helpful, generally speaking? What's your sense of that?
Um, I Not really. I think
Okay.
that what they're telling us, what we already know, that
Mm,
this is not on the ASC list. This is not, this is below the Medicare reimbursement. Like, so, like when I'm saying, somebody gives me the price and I say, but wait, this is below Medicare reimbursement. And they say, no, 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 you don't know anything. I just call the reimbursement support. They'll tell you all about it. Okay, we will call
okay.
the reimbursement. So let's call. And the reimbursement support says something like, "This is one of your first requests about the crazy stories." And the first word that come out of the reimbursement support something like, "Yeah, we have a lot of issues with ASCs." Say it one more time. You have a lot of issues with ASCs. Does your rep know about that? Um, and then they go into like, yeah, but if you only do the private payers, now we have to cherry pick the patients and only do this on the private payers and not do it on the patients that have Medicare. So all these things are silly, and in the reimbursement people, and I understand their job, right? They're trying to
Yeah.
convince me that everything is going to be all right.
That it's easy.
uh,
Yeah.
yeah, it's easy. But they have to understand that, like we're not in the game of cherry picking patients. We're not
Uh-uh.
in the game of cutting the corners and say, well, but why don't you do this in your procedure room, not in your operating room? Well, because it's a surgical procedure. That's why we do it in the operating. So all these
Right.
things that they suggest to you, and you kind of just say that's not going to
Yeah.
work.
Yeah. And
Yeah,
by the way,
or
you're having to do this is taking time, brain cells, effort, work just to get this approved.
right,
And like so it's work. And you have multiple of these going on and you have patients
yeah,
coming in and out. And you again, I keep coming back to all these things you have going. This is not your day job. It
right, right,
kind of
right.
so it should be a sliver of it, but it can be
Yeah, I
time,
mean, we do
right?
this, like I said, because we want to, if the surgeon comes up to me, he's like, hey, I really believe in this, we should be doing this, or it will differentiate us on the market that nobody's offering this, but we are offering this. So there is obviously, we are in the business of providing best care to our patients, and we want to be
Yeah.
and we want to differentiate ourselves. There's 3 or 4 ambulatory surgery center down the street. And so we do want to be on the cutting edge and provide the best care. But again, to your point, this is not a kind of a 5-minute conversation in the hallway on the way to the scrub sink. It's a whole process, and it is a business transaction. It's a contract. You have to treat it as such. So
Hmm, I love that. Uh, uh, That's so fascinating. So if I work, I'm the rep. I got a new product request. My surgeon clinical champion would like to use it. You're walking my product, my company, and me through this process, and you've got me interviewed, and you're bringing me in, and I'm answering these questions to your satisfaction, right? Let's assume we're doing all that. I'm knowledgeable.
right.
Um, what comes after that? Like you let's presume for a second everything I've said, talked, described checks out, and
Yeah.
it's a reasonable price. And you like, are we now free to roam the country, so metaphorically, or
Well,
is there more to
no,
it?
no, I think that, like there's a sort of a understanding of from the surgeon as well, that, if we're talking about one patient and the rep is asking me to buy 10 of these, that
Yeah.
this is indeed a something that he wants to introduce to his clinical practice, and he's going to be and going to offer this on a regular basis to the patients, and not just this one patient, or so just like something about this rep that's just not going to go away, and then just like, okay, fine, I'll just do it one time so you can just leave me alone, essentially. So if everything checks out, we schedule procedure. If we're asking for a sort of buy us buy 10 of these boxes, right, and place an order for minimum of 10, then I'm going to have an honest conversation with the surgeon. Like, we understand that if we do this, that you're going to really going back to this therapy or this procedure all the time, or do I really need to press this person on a bill only one
Hmm.
trial case and say, hey, let's just try it and see how it goes. And we're not going to invest until we get the outcomes and stuff like that. So this usually that's for the next step. And everything is checks out. We'll do the procedure. And then we'll obviously follow up on this and see if everything goes well. We usually engage with marketing and say, hey, we want to market this on
Right.
some of our channels, and we're going to highlight this, and yeah,
Yeah. And that's sort of a strategic win for the ambulatory surgery center. But you have to, like, that's downstream, that's down the
yeah,
road. Like, this is the on the ground nuts and bolts. What does Andre need? What do I need to bring him so that he can go through his process? Which, by the way, nothing you said is unreasonable. Like, I actually felt like that's why I I want this stuff to go through this process, because at the end of the day, 6 months down the road, we've done 7 of these now, and you're
right,
being reimbursed appropriately. Patients are doing well. Surgeon's happy. Hopefully,
win-win,
you're happy. Like, it's good for these things are not mutually exclusive. They're good for everybody. But
yeah,
that's what you have
absolutely,
to walk right. Like, you have to walk these filters, and it's been, man. Thank you for demystifying this and for teaching me some things today that I just never thought down to that on like pulling the thread all the way down. I'm sure it goes even farther, right? But at least when people understand, oh, I never thought about them having Andre's facility having to go through this, then they're less combative, and then they're like, okay, I'll bring it all. I'll get this information. I'll get it so that when he asks me for it, if we get to that point, I'm ready to give it to him.
yeah,
And then it makes it easy, makes your job easier, makes my job easier. But we're so many reps are learning this process in ambulatory surgery centers now, and people like you explaining this, I actually think is very helpful. And um, and to as we talked beforehand, to thank you, you get your choice of one of these fine pairs of socks, because we both gave blood, but only I got 2
that's
pairs
right,
of socks, and it says I'm supposed
yeah,
to give it to friends So you get to choose. We'll do it off screen because I understand. Like you have
Yeah.
you have a sartorial style that's well thought out,
No,
and
yeah,
you're going to
Mark,
want to
thanks
think
for
about.
no, thanks for inviting me, Mark. And I think that, and I think that, beyond the fact that, I consider you a friend and I also find
Yeah,
your content valuable, I think that the reason I'm doing this because I know I am also in this ecosystem and I understand that, we need to grow, the procedures evolve, there's new things introduced all the time. And I do want us to have a better ecosystem in the ambulatory surgery centers, and the vendors play a big role into that. And the more educated vendors, the more disciplined vendors we have, the easier for us to do what we have to do to bring the best therapies to our patients.